Thank you, Stephen. Thank you very much, and thanks, Harry, for getting me to Toronto. My last time in Toronto was 17 years ago when I was working in Ann Arbor with Analog, and afterwards, there's no chance to come here, so I'm very delighted to be here. So if you heard the talk by Pietro and Harry, you know the answer to this question. Does viral cure prevent XCC development? Is an obvious no. So what I'm going to do now is telling you how no, and what shall we do to make it become a yes. So in 10 years ago, when we first read the paper of lamivudine versus placebo in patients with advanced fibrosis and cirrhosis, we learned that it can reduce the development of complications. But when we study XCC development, the benefit is just at the borderline. So the p-value was 0.047 if we take into consideration our entire data set. But if we exclude the cases developed XCC in the first 1 year, then the difference fell short of statistical significance. So we do not know whether lamivudine can prevent XCC, but the caveat is there's no rescue therapy for resistance in this study. So we need more data. Then subsequently, our group tried to perform a meta-analysis based on the data available at that time, pulling together a few studies. Most of them used lamivudine as a backbone, but some of them did have rescue therapy. And we found that the relative risk of XCC development was only 0.22. So in other words, NA therapy can reduce the risk of XCC. But that's all history. It's because now we have much better new therapy. Most of us are using entecavir and tenofovir. Drug resistance is not a big problem. They are very potent in viral suppression, and we do need new data to see if this better news can prevent XCC development. Well, for tenofovir, an elegant study was performed by Ray Kim and his group. It's following up 641 happy patients, 13 developed XCC, and he did not perform a randomized control study or compare with historic cohort, but he used the RICH-B model, which is a model derived in Asia predicting the risk of XCC development in non-cirrhotic patients. So this is a very conservative model to predict the risk of cancer, and he's shown that using tenofovir therapy, the observed XCC incidence is still lower than the predicted XCC risk. So he concluded that tenofovir may be effective to reduce the risk of cancer, even compared to a very conservative model. But of course, this model is developed in Asia. Whether it's the same as in America, well, we do need more studies to confirm. But there are more data on entecavir, but most of these data are actually from Asia. Here I show you 3 studies comparing ETV-treated patient versus untreated historic cohort, and all 3 studies use propensity score matching so that the baseline characteristics of patients are relatively matched, and then compare the risk of XCC and the entire cohort of patients. Now the first cohort, the Wu et al. You can see the number is huge. It's not a typo. It is a national database, so there are more than 20,000 patients in each group. The subsequent 2 studies are the hospital cohorts in Japan, so there are only a few hundred patients there. And in 3 studies, you can see that the adjusted hazard ratio of XCC development was somewhere between 0.23 to 0.37. It's very comparable to the meta-analysis that we have done, the relative risk of 0.22. So overall, well, I think that the idea is NUC can reduce the risk of XCC. But if you look closer on the yellow bar, which is a treated patient, we still see cancer. So we have not prevented XCC development, we have just reduced the risk of development. So and then we try to dissect into this data set and see which group of patients respond best, which group of patients respond worse, and what do we need to do to eliminate XCC risk. So when we go into the Japanese cohort, when we divide patients into cirrhotic and non-cirrhotics, we see clearly that the benefits of entecavir therapy is most prominent in cirrhotic patients. The reason is because cirrhotic patients have a much higher risk of HCC. So if we can suppress the viral replication, we can drop the 5-year HCC risk from 38.9% to 7%, already a tremendous reduction. But if you look at the non-cirrhotic group, the HCC incidence among untreated patients is very low. The control group was only 3.6%. Actually, it's much lower than the cirrhotic patients under treatment. So even if we treated them with entecavir for 5 years, we could not see any meaningful difference. The incidence was still 2.5% for entecavir group. So in this Japanese study, it's concluded that we do have survival benefit documented in cirrhotic patients. In Hong Kong, we performed a very similar study with both cirrhotic patients and non-cirrhotic patients, and again, we could only demonstrate benefit in cirrhotic patients. Here we have 482 ETV-treated cirrhotic patients as compared to 69 untreated historic control, and we found that in all complications, including a composite endpoint hepatic event, liver cancer, liver-related mortality, all-cause mortality, they're all reduced by entecavir therapy, but these are not shown in non-cirrhotic patients. So when I put the Hong Kong study, Taiwanese study, and a Japanese study together, well, clearly there's a reduction of HCC risk in cirrhotic patients. The control group, that's untreated control, the risk is somewhere between 5 to 8% per year. So this is an estimated risk. Just use the incidence divided by the number of years in that particular study, as compared to the treatment group, that is 1.4% to 4%, a reduction of by hazard ratio of somewhere between 0.5 to 0.7 in cirrhotic patients per year. Well, but there's still some controversy. In the biggest publication so far, that is a Taiwanese national database, including more than 40,000 patients in this study, they found 3 independent factors predicting the benefit of actually all types of NUC in HCC reduction. One is age, younger age is better, another one is cirrhosis, no cirrhosis is better, and also third is diabetes. So the controversial factor is actually here in a cirrhotic patient, because when we look at the cohort studies in Hong Kong, in Japan, it seems that cirrhotic patients have the best benefit. But in these bigger studies in Taiwan, non-cirrhotic patients have the biggest benefit. And so we try to drill to see why the data is so interesting. So before we look into this database, I want to show you another database, again from Taiwan, same country, so I believe ethnicity is not a problem, but from a different center. So this is actually from National Taiwan University. They have a retrospective prospective cohort called the ERADICATE-B cohort. So they use ultrasound to exclude cirrhosis. So these are so-called non-cirrhotic Taiwanese patients, follow-up for more than 14 years, and they found that the risk of HCC, again, is related to HBV DNA, but this is not the main point I want to show you. The main one I want to show you is that usually we start antiviral therapy in these patients when the DNA is more than 2,000, sometimes maybe more than 20,000. So the time when we start therapy, the risk of HCC should be somewhere maybe around 0.5% per year. And among these non-cirrhotic patients, even the very high DNA, the risk should be less than 1% per year. So this is what the Taiwanese cohort taught us. But when we go back to the 3 studies, Hong Kong, and Japan, in non-cirrhotic patients, well, most of these studies actually have a similar HCC risk, except the national cohort study in Taiwan. The annual risk of HCC is about 3%, which is much, much higher than the another Taiwanese study shown. So we are wondering from this national database whether there's underlabeling of cirrhosis, because if you have ever entered your diagnosis code in a national database, you know that sometimes people do mislabeling. So there are some cirrhotic patients that are actually included in that database that give rise to this very, very high HCC risk in non-cirrhotic patients, and therefore a huge benefit can be demonstrated with antiviral therapy. So this is a speculation, but at least some explanation to the very different result from this huge study as compared to other cohort studies. So in our center, actually we try to use liver stiffness measurement to replace the cirrhosis labeling because we know that it is very difficult. So we have performed a prospective study among more than 15,000 hepatitis B patients. About a third of them received antiviral therapy, followed by a mean of more than 5 years, 38 developed HCC, and we used 4 factors, including age, albumin, HBV DNA, and liver stiffness measurement. And if we use about 0.5% annual risk as the line for therapy, then patient with an intermediate high risk patient deserve treatment, while patient with a low risk based on the score can avoid antiviral therapy, because at least we may not have benefits in terms of HCC reduction in the low risk group of patients. So it's one way that we can play away from the labeling of cirrhosis. We're moving a little bit away from the overall data. Then we look into what can improve HCC reduction. Now, one speculation, we use a better nuke, then we should improve HCC reduction. So there are 2 studies comparing use of entecavir versus lamivudine. Again, these are not randomized studies. They all use historic data with different cohorts. And one Korean study, one Japanese studies have been published. There's no difference in non-cirrhotic patients, and in cirrhotic patients, the data from these 2 studies are controversial. So we really do not know whether different nuke has a better HCC prevention, particularly if we use proper rescue therapy regimen for drug resistance. But we know that if a patient can achieve HBsAg0 clearance, then there's a much better clinical outcome. So this is coming from very recent publication in Korea, showing patients with S0 clearance, the blue line, they have a much better overall transplant-free survival and also much lower incidence of hepatocellular carcinoma as compared to patients who did not achieve S0 clearance on different types of antiviral therapy. And these patients were propensity score matched, so the baseline factors are very comparable between the S-loss group versus a no S-loss group. Well, but this is difficult, we know, but at least we have to achieve HBV DNA suppression. So the Virgil study is actually a retrospective cohort study from 10 European study centers with median follow-up 20 years. 89 patients have liver cirrhosis, and in this study, because the number of patients was small, they look at a composite endpoint, that is a combination of liver decompensation, jaundice, variceal bleeding, ascites, encephalopathy, HCC, and death. For patients who had a virologic response, which was defined as the DNA suppressed below 80 IU per ml, the blue line, it is clearly the probability of this composite endpoint is much lower than those with no virologic response. So the lesson we learned is, even if we start a patient on entecavir, we do need to see a complete viral suppression. Otherwise, the benefit is incomplete. So this benefit is again shown in a study in Hong Kong, in our study in more than 1,500 happy patients for using entecavir for a median of more than 3 years, 22% cirrhosis. I want to draw attention to cirrhotic patients. The duration of virologic remission for more than 2 years is an important independent factor predicting HCC prevention. We could not demonstrate this clearly in non-cirrhotic patients, probably again because of the low event rate in the patient who could not achieve viral remission for more than 24 months. But at least we all agree that even if we put patient on antiviral, we do need a complete DNA suppression to achieve a maximum benefit. Now, this is a very recent Korean study. I think it is already published very recently, and it compares again incomplete responder versus complete responder to various antiviral therapies. But in this study, because the primary goal of the study is not comparing incomplete responders versus complete responder, but they want to compare with untreated inactive carriers. So the way they define response was DNA less than 2,000 IU per mil. So this is not undetectable HBV DNA in this Korean study, but at least for those patients who have a lower HBV DNA, you can see that the risk of HCC is much lower from year 1 up to year 5, and the benefits of better viral suppression actually improves with time. So here is actually a comparison between the complete responder versus inactive carriers. And inactive carriers are patients who have not received any therapy, but they themselves, just because of the good immune control, they can control the virus to DNA below 2,000 IU per mil. And we still see that these patients, regardless of the serotic status, have a much lower HCC risk than patients requiring therapy. So it seems that antiviral therapy can reduce the risk of HCC, particularly in serotic patients, but it still cannot reduce the risk down to a patient who does not require any antiviral therapy. So maybe the immune control plays a part in HCC prevention, but definitely more studies are needed to illustrate this difference. Now we know that we need a complete viral control, but can we predict which patient will have a complete viral response on therapy? Well, a on-treatment predictor called primary non-response was raised by AASLD, defined as less than 2 log reduction at month 12, and also defined differently by EASL by less than 1 log reduction at month 12. But this so-called primary response is very uncommon. If you look at 2 cohorts from Korea acting together with more than 1,500 patients, primary non-response only occur in less than 2% of patients. And among patients who have primary non-response being followed up for longer time, 3 to 4 years, all of them had undetectable HBV DNA. So in other words, we have a definition of primary non-response, but actually it has little clinical implication in terms of complete virological suppression. But the more important predictor is actually what we call partial response. A partial response was defined as less than 1 log reduction, but detectable DNA at month 12. So the couple of studies, one from Hong Kong, this is from our university, and 3 different studies in Korea looking into the incidence of partial response. And they found that partial response occurs somewhere between 15 to 30% of patients after 1 year of treatment. Although you can see that in these cohorts, the preference of E antigen positive hepatitis B differ. Among patients who have partial response, after 2 to 3 years of therapy, actually only half to 3/4 of them could achieve undetectable HBV DNA with entecavir. In other words, if a patient who still have a detectable DNA at the end of year 1, we continue therapy for 3 years, maybe 25 to 50% of them will still have a detectable HBV DNA. And we know that this is not desirable because there is still a significant risk of HCC as compared to those who have complete response. So definitely something has to be done in these patients to maximize the benefits of antiviral therapy. But tenofovir has been tested in some very small cohorts. This is one of the examples published by Kevin Pang in his group. 14 patients on entecavir for about 5 years. All of them still have detectable HBV DNA, and then they shifted to tenofovir. And you can see that after 1 year, all patients had undetectable HBV DNA. So tenofovir is probably one of the so-called, we do call rescue, but a therapy that can help to improve viral suppression in partial responders to entecavir. So this is another study looking into incomplete viral suppression by entecavir. These are all Asian patients. The DNA at time of switch is around 3 logs. So they compare entecavir plus adefovir, tenofovir alone, or combination of entecavir plus tenofovir. This is not a randomized controlled trial. There are only 3 different cohorts based on the choice of the physicians. But at least we can see that using tenofovir-based regime is much better than a adefovir-based regimen. and adding entecavir or not may not affect the viral suppression, but the number of patients is very small in this cohort. At least based on all those small cohort studies, tenofovir switch is good enough to manage partial responders to entecavir. But then how about tenofovir partial responders? Well, this is actually recently published studies among E-positive patients with high viral load, and most of them may be in the immune tolerance phase. We compare tenofovir monotherapy versus Truvada, which is tenofovir plus anthracycline, and we found that patients who had a combination therapy had a higher chance of response. So maybe combination therapy will help to improve the viral suppression by tenofovir. But however, these are treatment-naive patients. These are not partial responders. For partial responders, unfortunately, we do not have good evidence suggesting that Truvada helps. So this is actually the pivotal studies of tenofovir. At the end of week 72, for those patients who had detectable DNA, had the right to choose whether they want to carry on tenofovir monotherapy or they want to change to Truvada, which is combination therapy. So this is the 5-year report showing that there's actually no difference in terms of HBV DNA undetectability at the end of 5 years, regardless of whether the patient is on tenofovir alone or on a combo therapy with anthracycline among tenofovir partial responders. So we still need more research to see whether we can help to improve the DNA suppression among tenofovir partial responders. So to sum up my talk, I think there is sufficient data to suggest that antiviral therapy can reduce the risk of HCC. Most studies come from Asia, but at least in Asian cirrhotic patients. But the annual incidence of HCC still had 1.4 to 3.9%, so we have not completely prevented HCC development. There are conflicting data on the benefit of antiviral therapy among non-cirrhotic patients because the annual incidence is very low. Even among untreated patients, it's somewhere between 0.5 to 0.7% per year. We know that complete viral suppression is better. It can improve HCC prevention. Only 50 to 74% of partial responders actually to entecavir at 1 year have complete HBV DNA suppression at 3 years. Tenofovir switch is effective for entecavir partial responders, but we do need more data to see how we can help the tenofovir partial responders. Thank you very much for your attention.